Thank you, Bruno. And Linda had to leave. The 5 or 6 different questions that Linda was posing at the end are very challenging. How to comply with judicial rulings. The Court of Costa Rica has done some work, but when it comes to collective rulings or structural rulings, it is quite a daunting task. I want to give the floor to Jaime Caro. Jaime Caro is a clinical physician and internist. He practiced medicine in Canada, and he's a professor of epidemiology and biostatistics at University of McGill. He is also a senior vice president for United Biosource, and he has been working on different models, quantitative models, that are useful in setting priorities. He has done some work with different countries, including the country of Germany. So he is going to give us an overview of the issues and his thoughts about what countries are dealing with now. Over to you, Jaime. Thank you.
Thank you. Imagine for an uncomfortable moment that you're at your doctor's office, and through a haze of disbelief, you hear your doctor tell you that you have, in fact, a very aggressive form of cancer, and it's in an advanced stage. In your anxiety, you hear the doctor telling you that in the past, this cancer was very deadly, and you would have only had a few months to live. But as you sink into despair, you hear that the doctor is saying that there is a new treatment available for this cancer. It's an immunotherapy, and it is a miracle of modern science. They take your own cancer cells, and they take them to the lab, and they create a personalized, specific treatment to target that cancer. And with this new treatment, because it is targeted specifically to your cancer, the chances of cure are very high. Perhaps not 100%, but very high. Moreover, because it's so targeted, so specific, there are almost no side effects. There will be nothing bad that happens. So you have gone to despair. You now start to feel a bit of hope. You leave the doctor's office in a very emotional state. Over the next few days, you are shocked to discover that your healthcare system will not pay for this new treatment. You cannot believe what you're hearing. You investigate a little bit, and you find out that there was a health technology assessment, an economic evaluation done by an agency in your country, and they determined that this new treatment, which costs $25,000, pick your monetary unit, $25,000 equivalents per year to keep you cured from this cancer. And the agency that has determined that it is not, you hear this terminology, cost effective. You are disbelieving of what you're hearing. There is something there that gives you a good chance of curing your cancer with few side effects, but the system cannot cover it for you. You talk to your friends, you talk to your family, and one friend who is a lawyer says, but haven't you heard that our country adopted the right to health? So you look into this a little bit more, and you find that nobody can really tell you what the right to health means, but it seems at least to mean that you should be covered for effective treatments. And certainly you have a terrific case here. This could not possibly be a more dire situation, a more effective treatment. So you ask your lawyer friend what you should do, and the friend says you need to go to the court, to the Constitutional Court or the Supreme Court, and you need to apply for an amparo, a safe harbor that will protect your right to health, your right to this treatment that can cure you of this terrible cancer. So you say, all right, that's what I need to do, but being a very conscientious person, you start to ask yourself some questions. If the system pays for my treatment, who will have to give something up in order that I get treatment for my cancer? And how will that decision be made? Who is going to make that decision in our system? Where is the money going to come from? Which patients are going to be disadvantaged so that I can gain this right to health? And if everybody has the right to health, what about their right to health? Isn't it to be protected as well? And so you realize that this is a very, very difficult problem. And it is this Gordian knot that we face in medicine, in the judiciary, in the system in general, in society in general, that I think we are meeting here today to discuss. Sadly, I can say that nobody has figured out how to cut this knot yet. We have some ideas, we have some initiatives, but after more than 30 years of working on this, we have not quite figured out how to solve this extremely difficult problem. And this problem is getting both more frequent and more difficult. You heard I wrote down some of the terms that were mentioned by the introductory speakers: universal coverage, right to health, innovation, sustainability, looking for a win-win situation. There was also the mention of soccer, but we'll leave that one out of the series. These are all very much what causes the Gordian knot. Medicine is getting, the medical establishment, the research establishment industry is pursuing this idea of personalization for very good biological, clinical reasons. The more personalized we get, the better the effects, the fewer the side effects. It's clearly the way to go. But as we pursue personalized medicine, what happens? The pool of patients whose payment through the government or themselves will support the development of those treatments gets smaller. So for industry to be able to develop those treatments, they need to charge more, because developing the treatments doesn't get any cheaper. In fact, for personalization, it can get more expensive. But you have these pressures of an increasingly productive system which delivers more for the patients and the society, but creates an enormous pressure to fund it. And the funding problem becomes more difficult as we get better at producing these personalized medicines. The best known attempt at dealing with this Gordian knot is the system that is used now in many countries, the UK, Canada, not France, not Germany, but Australia as well, and most of the Nordic countries. And the idea of this system is that you calculate the extra cost that this new treatment is going to bring compared to the existing treatments. You calculate the extra benefit on the health side, and you create a ratio of this, which is the efficiency of the system, its capacity to give you a return on investment, or, as is well known in our field, the cost effectiveness of this treatment. So you have this number that tells you something about the efficiency of the treatment. What do you do with this number? So I have a number for the efficiency of this cancer treatment that could cure me, and we don't know how to answer that, because it requires that I express for my system what is an acceptable efficiency. There have been good attempts at doing this. The WHO has proposed that we use 3 GDPs per person as the threshold at which we consider something efficient. Many countries amongst you here have said 3 GDPs is too expensive. We'll go to 1 GDP. Immediately revealing that there's no basis for the 3 GDPs. You can pick 1 GDP, half a GDP, 17 GDPs, or any other number you like, because there's no theoretical foundation, there's no empirical basis for that threshold. So the first problem we have is we don't have this threshold. We don't know how to compute this threshold. We don't know where to get it from. Even if we leave that aside and we say, let's just pretend that the WHO knows what it's talking about and we'll pick the 3 GDPs per person as the threshold, we still have a lot of problems. Because if I have this new treatment, and let's say that the $25,000, because it gains me 40 years of life, is within 3 GDPs cost effectiveness, that means the system has to pay for it. But where does it get the money? What does it take out? Do you take out the next less efficient therapy? What is it? How do you identify it? Suppose that the next less efficient therapy in the system that is being covered is a therapy for newborn premature babies. Do you disadvantage them in order to pay for this new cancer treatment? How do you decide where to go get the money, what trade-off to make? So the fact that I identify a threshold doesn't actually tell me what to do, what decision to make. Who makes it? Is it a council? Is it the judges? Is it the parliament? Is it a new group of wise older citizens that make the decision? How do we decide? Do we do a plebiscite like they do in Switzerland for everything? Not so clear how we get to those values and get to those decisions. So we have technical difficulties in solving the threshold problem. We have social difficulties in getting to this. So in pursuing this, countries have taken different approaches. Many in Europe have started to reject the threshold approach and say it's not workable. It leads to decisions that are socially difficult to accept. And so we need a different way to do it. So, for example, in France and in Germany, they have decided, two of the biggest markets in the world, they have decided that what they will do instead is look only at the health side, only at the health benefit. I think many of you judges are sympathetic with this idea. They will say, okay, does it work? Does it work better than what's there? How much better does it work? And they have a rough classification where they say, if it's a lot better, we give it, say, number one rank. Medium better, and they don't define, they're very careful not to tell you what medium means, because that way they can play with that. It's a socio-political decision, so they don't want to force themselves into a box. They say medium better, number 2. A little better, number 3. No better, number 4. Worse, number 5. If you get number 5, you're out. If you get number 4, you have to price your product at the level at which the existing products that you are equal to are priced. If you get a number 3, we'll give you a little bit extra, and we'll negotiate what that is. If you have a number 2, or even better, a number 1, meaning you are massively better than the existing product, then come and see us. We'll go into the back room behind closed doors, and we'll figure out a price that we can pay and that rewards you for the innovation that you came up with. And in addition, they say, we won't tell anybody what the price is, so that you don't have to worry that your price in other countries has to come down because we've brought it down in our country. Since Germany and France are leading markets, they influence many of the other markets in the world. So this is how they've tried to cut this Gordian knot and say, we need to decide, does our population deserve this treatment? And if they do, we need to find a way to cover it that respects the industry's need for funding to develop new treatments, but also respects our budgets and makes it possible to cover it. France has had experience now for some years with this approach and has been quite successful. The French healthcare system is one of the better ones in the world, and they have, in some cases, almost 200% more products covered than the UK system, which uses the threshold approach. Germany has just started this approach in the last year, so it's only 8 cases so far that are available, but they're hoping to replicate the success that France has had. So this is where we are in the system right now. We clearly have the Gordian knot. We had one attempt to cut it that came over the last 20 years, which has not been successful. We have some new attempts in the last 5 years, which have demonstrated some success and provide some hope, but they require this socio-political context where you're willing to do things that way, where there is less transparency, than perhaps we would all like to see in the system. You have to give up some transparency to make that work. And whether that's acceptable or not to many systems, we will see. Lastly, I'll mention that another way to try to cut this Gordian knot is to accept that you will not be able to cover everything, not even things that look extremely efficacious. And that the way you will decide which ones you cover is based on some measure of need, a scale of need. How important is this treatment to your population? A difficult scale to develop, not trivia technically. And so far, the Netherlands is the most advanced country in attempting a need-based scaling, where you try to say, treating this cancer or treating this premature baby is considered a high need for our country, and treating this infection in the skin is considered a low need, or something like that. So they've been developing a scale of need and using that to try to develop the prioritization. I'll leave you with those thoughts and look forward very much to the discussions for the day. Thank you.